سكيلز اللي بتقابلنا كل يوم في حياتنا، حتى من اول من ساعه ما بنتخرج بنلاقي الجونيور دكتورز معانا. لو انت في اي مكان بتلاقي فيه حد تحتك جونيور throughout all of your life. ثالث سكيل مهمه جدا ريسيرش، الدكتور وائل ان شاء الله هيدينا توك عليها ان شاء الله على الريسيرش ميثودولوجي اند فاندمنتالز. ورابع حاجه اللي هي الانتربيرسونال اند مانجمنت سكيلز. دول اربع رجول اللي المفروض الدكتور دايما ماشي بيهم، يعني هنقول at some stage المفروض يكونوا equal to each other ويحاول to improve اي ليج فيهم. فان شاء الله احنا عندنا interpersonal skill شغاله دلوقتي في الانترفيو سكيلز، ودكتور وائل ان شاء الله يدي لنا السكيل الجميله عن الريسيرش.
شكرا دكتور احمد. يعني احنا the last time we were here كان المفروض في البلان ان احنا ان شاء الله كنا نتكلم على ادي محاضره صغيره على ال fundamentals of research or just basics of research. كانت هتبقى 10 دقايق ربع ساعه، بس يعني انا حسيت ان 10 دقايق ربع ساعه مش كتير، وحسيت ان انتوا الحمد لله المره دي هيبقى عددكم قليل فاقدر ان انا اخد راحتي، فخليناها ساعه ونص. عندي captive audience لمده ساعه ونص. الفكره اللي احنا بنحاول نعملها دلوقتي انه يعني at least يعني what I was directed to do انه في ناس كتير لسه ما ابتدتش تعمل research نهائي and would like to know the absolute basics, the absolute fundamentals starting from scratch. فممكن البداية إلى حد ما يكون في عدد كبير مننا عارفها، بس I still think it's important that we at least touch upon those elements before we move on to the details. اللي هنبتدي بيه في الأول إن احنا يعني بعض النقط اللي هنتكلم عليها النهاردة. First thing, what exactly is research؟ يعني إيه research؟ Why is it even important to do it؟ احنا معظمنا اتربينا في culture طبية بتعتمد على do، مش بتعتمد على research what you do. فايه اهمية الكلام ده؟ ولما بنيجي هنا بنفاجئ ان الموضوع ده موضوع كبير جدا. في الانترفيوز اول سؤال بنتسأله what research have you done؟ وما بنبقاش محضرين الاجابة. حاجة تانية we'll touch upon what is evidence-based medicine، وبعديها what are the different levels of evidence. أصلاً يعني إيه كلمة research؟ يعني إيه evidence؟ وآخر حاجة اللي هي هتاخد ال big bulk where do I start؟ how do I do research؟ أبتدي منين؟ والsteps. فأول 4 نقط we'll try and kind of rush through them quickly to give us enough time to focus on this. So, what is research in the end? إيه المقصود بكلمة research؟ هو research في حد ذاته is a process. It's a process that we do in order to obtain knowledge as much as we can. فإحنا to try and discover knowledge we're supposed to do research. فإحنا بنعمل إيه بقى؟ بنروح نقرأ عن التوبيك. We research a topic. We read a topic. Now, read about a topic is one thing and researching is another thing. And we need to start getting our wording right. Because one of the things that really annoys the people you're working with here is starting to use wrong wording. Not when it comes to research, but it just shows that because you don't have the basic knowledge and the understanding of what that word means, it shows that you don't really know what you're talking about. And whoever's worked here for a while now, you really understand how much they hate people talking about a topic when they don't know what they're talking about. So it's very important to understand that research is not literature review. Okay? The fact that you've gone and read about a topic does not mean that you've done research on the topic. When your consultant or your colleague tells you, what research have you done? Well, I read about this, I read about that. Reading is not doing research. Reading is a part of doing research. So literature review is one simple portion of research. So research does not equal literature review. If you read about something, you can say, I've done a literature review. But don't نحاول نكبر كل حاجة احنا عملناها. أنا عملت research في الموضوع ده. How did you do it? What methodology did you use? What was your question? How did you prove it? احنا ما عملناش أي حاجة من الحاجات دي. أنا بس قريت. Okay? The other thing with our wording, literature review means literature review. You've read the literature. Literature review does not mean systematic review. برضو بعضنا في بعض الأحيان we start to come up with what have you done؟ أنا ببقى عايز أقول إن أنا قريت في الموضوع كويس in a proper way فبقول I've done a systematic review. A literature review, if we're talking about level of evidence, that's probably level 0 because it's not research. It's only a part of research. Systematic review from the level of evidence is level 1A on the scale. How are you going to get level nothing to level 1A? It doesn't work. فلازم نبقى very careful with our wording. Okay? Research بيتكون من إيه؟ بيتكون من a few things. أول حاجة, so in order for you to actually have to have done research in a topic, you need these 3 steps. You need to ask the question, سؤال معين عايزين نعرف إجابته. نبتدي نعمل the work to find the answer to that question, which we will talk about later. And then once you've done the work, you've got your results, how are we going to communicate that to the community? The question, does it have to be asked, a question that's been asked before? Not necessarily, and we'll touch upon that in a minute. نيجي بقى للسؤال المهم جدا جدا جدا. أنا بوجع دماغي ليه؟ أنا دكتور، أنا جراح، أنا دكتور تخدير، أنا راجل بتاع باثولوجي. أنا مالي ومال الريسيرش، أنا راجل clinical. Why is it important to do research? Now, I'll probably, before I put up the slide, I'll ask the question because each and every one of you who's going to go for an interview at any stage will be asked that question. Why is it important to do research?
To be updated with literature.
So you're doing research. What's that got to do with you being updated? If you're physically doing it yourself and writing, why would that make you updated? Because in order to do it, you need to do your literature review.
Yeah, review.
Okay. Why is it important to do research?
Is what I'm doing to the patient now is really beneficial? That's the question.
So
And
you're
is
talking
the
about
best way to do it?
what is the best way to treat a patient? What is the best way to treat any patient?
Go with the guidelines.
Evidence-based.
Evidence-based. Not necessarily through the guidelines, and I'll tell you why in a second. So evidence-based. Okay. So ideally, the way you're going to approach your patient is going to be evidence-based. Okay. So that's another reason to do research. Why is it important to do research? Bess?
Improve my writing ability.
Improve your writing ability. So you're not a novelist. You're a cardiac surgeon. Why is it important to improve your writing abilities? Who cares?
To add to the knowledge.
Can help in teaching.
Okay. So improving your writing ability, the whole point, one of the things on research is that it instills self-discipline. Writing is really, really hard for clinicians. But as clinicians, you have to have some degree of self-discipline. So it does instill self-discipline. So we'll go through some of the things there. It instills self-discipline, as we mentioned. It enhances your critical appraisal abilities. If you understand research, you understand, as in you know how to do research, means that if you see a paper, a manuscript, and you read it, you can tell straight away that it was done correctly or not. Is it useful for you or not? You can critically appraise that article and decide, will that change my practice or not? هتكلم بمنتهى الصراحة. عدد كبير مننا، أكيد مش كلنا، اتربينا في مصر إن إحنا دي اتنشرت في International Journal. واستغفر الله العظيم as if إن ده قرآن. طالما اتنشرت يبقى خلاص. There's no such thing. كمية البيبرز المنشورة اللي يعني لو وظف الكلمة تبلها وتشرب ميتها أكتر بكتير قوي من البيبرز اللي you would really adjust your practice based on them. Okay? And once you can critically appraise papers, then that will help you with your evidence-based practice. A few other discipline things, the fact that you're able to write and get critiqued about it, it teaches you critique acceptance, which means that إن أنت ممكن حد يوجهك and working as part of a team is extremely important. The other thing is an ego thing. Are you a consumer of the literature or are you actually providing the literature? In an interview, you're probably going to have to come up with one or two of those that show that, yes, you're a team player, you will accept somebody telling you what you've done is right or what you've done is wrong, that you will work according to evidence-based medicine, and at the same time, احنا مش بنعملها لله والوطن، أنا برضو بعملها for something for myself، إن أنا شايف إن دي حاجة it will promote my career, and at the same time, I'm adding to the body of literature, I'm not just a consumer. Okay? لأن هم عارفين لو هو كلام إنشا ولا أنت برضو بتتكلم بحاجة إلى حد ما يعني فيها لازم يكون في شيء من الأنانية. إحنا كدكاترة لازم يكون عندنا النقطة دي، ولو أنت ما حاولتش تظهرها بطريقة بسيطة معناها إن أنت يعني تتكلم كلام إنشا. Now, I'll come to this evidence-based medicine. But before I go into details, I'll just back again to the why is it important. الحمد لله كلنا بنعرف نقرأ ونكتب. Which comes first, reading or writing? Reading.
Yeah.
There's no way you can write if you don't know how to read. Okay? You might be able to read, but you just physically can't write. Okay? So, if I'm interviewing you, and I ask you, have you published anything? And you tell me, I've done this, I've done that, I've published this, I've published that. So you can write. I know for a fact that you can read. Full stop. I don't need to go any further. I know you can read because you can write. So I know the chances of you following evidence-based medicine is quite high. But if you have never done any research, then it becomes, well, I don't really know if you can read or not. And that's the problem. How am I going to gauge that? Okay? So that's why it's important, because it gives whoever's interviewing you the peace of mind that you definitely will follow evidence-based medicine. So what is evidence-based medicine? You mentioned that we'll treat patients according to guidelines. And then we said, no, we'll treat them according to evidence-based medicine. What's the difference? What are the three components of evidence-based medicine? By the way, again, that is an extremely important question for any interview. You need to know what is evidence-based medicine. When you say you practice evidence-based medicine, you need to know what we're talking about. So practicing evidence-based medicine is that you are providing the best available, you're using the best available evidence to make a decision about your patient. And it includes 3 components. The best evidence, which might include the guidelines, and your own clinical expertise, as well as the patient values and expectations. Evidence-based medicine is in the middle there. It's all 3 together. You can't treat a patient just by guidelines. If you follow the guidelines in every single case, yes, you probably will be fine for most of them, but there will be the odd patient that will not be appropriate in that particular scenario. You have to use your clinical expertise there. And then there'll be the odd patient who doesn't want to follow the guidelines. And in this day and age, and in this country, this is way more important than this. So you have to be careful. When you're using evidence-based medicine, patient comes into the fore and is extremely important. All right, so we're talking evidence-based medicine. So what we're reading, is it really evidence? How can we tell if it is evidence or not? What are the different levels of evidence? We already mentioned there's level something and then all the way to level 1. So does anyone know which one is which? What's level 5, what's level 4, 3, 2 and 1?
Yeah, one is the meta-analysis and the systematic review.
So
It's in A and B.
yeah.
A is the meta-analysis for the controlled
Trials, okay.
trials,
Randomized
and then
trials.
for the non-controlled trials B, and then we go for level 2, which is the systematic controlled trials.
Okay.
And level 3 is the non-systematic controlled trials, and then level 4, which is the case series, and also non case series.
Okay.
And the 5th is the clinical experience. And
Okay. I'll tell you what, let's probably adjust that a tiny little bit. We're nearly there. So there's a pyramid where level 1 is the top of the pyramid. So at the very bottom of the pyramid is our expert opinion, our case report. Okay? So that's our level 5. أنا بعملها بالطريقة الفلانية. Yes, you might be العلامة اللي في الموضوع ده worldwide. That's absolutely fine, and we will listen to you. But in the end, that's the level of evidence. It's level 5. A case report is still level 5. A case series is level 4. What's the difference between case report and case series? Case report is 1 patient. Case series, 10. Okay. Level 3. Case control studies. And we'll talk about different types of studies in a few minutes. Level 4, cohort studies. Level 5, RCTs, randomized control trials. And what you will notice is that case control studies are level 3. Systematic review of case control studies is level 3. Cohort studies is level 4. Systematic review of cohort is level 4. Sorry, level 2, apologies, level 2. And randomized control trials are level 1. Systematic reviews of randomized control trials are level 1. So that's where the difference is. The type of the study dictates the type of the systematic review or meta-analysis, and your systematic review and meta-analysis stays within the same level, albeit that your systematic review will be level, let's say, 3A, and the actual study will be 3B. An RCT will be 1B, and a systematic review or meta-analysis of an RCT will be 1A. Okay? So if we break it down into 1A, 1B, and so on, you'll see that 1A is systematic review of randomized controlled trials, 1B is the individual randomized controlled trials. And it's not just that, it's also the quality of the study, the quality of the trial. Because you're going to see that 1B is individual randomized controlled trials. 2B includes RCTs as well, but it's low quality RCTs. So the quality of the study, the design, and we'll talk about how to know if it's properly designed or not, could easily move your RCT from a 1B to a 2B. Okay? So they're the different levels of evidence. All right, very good. So let's start. So far we were just talking. Where do I start? كلنا بنيجي هنا كلهم بيعملوا research أنا عايز أعمل research وبعدين أبتدي منين؟ So what's the first thing you're going to do? When you talk to your consultant or your colleague, I want to do research. What's the first thing they tell you?
Go and read.
Read.
Go and read. Okay.
Search for a topic.
Search for a topic. Okay. So the first thing they ask you to do is search for a topic. Now, obviously, they're very wise about the question, what they tell you to do, because in order for you to search for a topic, you have to read. So they know what they're doing. So the first thing you're going to do is the question, the hypothesis. Okay? What is the hypothesis that you want to prove or disprove? Hypothesis in general is just an educated guess. But in order for you to actually talk about a hypothesis scientifically, you need to follow certain steps in order to prove and test that hypothesis or disprove it. Now, scientific hypotheses, they're generally based on previous observations. We've seen things before, and based on that, we have built a certain idea that this might be a good theory, a good hypothesis, and that this hypothesis can only be explained within available scientific theories. Now, as a vascular surgeon, I'll give an example from within vascular surgery, a very simple, broad example. Smoking is a risk factor for amputation in peripheral arterial disease. That's the statement that I am claiming. I am now telling you that smoking is a risk factor for amputation in peripheral arterial disease. So, ده الكلام اللي باللغة العامية. Let's put it into scientific terms. Let's actually make it into a hypothesis that I could write. There's something called the null hypothesis. You've probably all heard that word, the null hypothesis. When they ask you what's the topic, what they want from you is the null hypothesis. You're going to them telling them, well, smoking might decrease if the patient stops smoking, it'll decrease the risk of amputation. The way their mind will switch is, tell me your hypothesis, tell me your null hypothesis. Stop waffling around, be precise. So the null hypothesis means that there is no relationship between the things that you're going to measure and the outcome. You're telling me that smoking affects amputation rates in patients with peripheral arterial disease. Isbitli. So what's the baseline? What is the actual baseline?
No relation.
There is no relation. Okay? If I'm telling you that this microphone is black, that's what I'm claiming. I'm telling you it's black. If we're thinking scientifically, then we have to say, well, okay, prove it. Well, I'm telling you it's black because of the refraction and the reflection of light. It actually absorbs the light, and that's why it's giving this color. Okay? But you have to be able to prove what you're talking about. So, as a default, everything is there is no relationship. So our null hypothesis, smoking is not a risk factor for amputation in peripheral arterial disease. And when you're writing in a manuscript, ideally you should be writing your null hypothesis. Your null hypothesis is that there is no relationship or there is no effect of this medication on that. And as a general rule, the null hypothesis is what is assumed to be true until the evidence proves otherwise. You have to come up with the evidence to prove that. Okay? So if you can prove otherwise, so smoking is not a risk factor. That's our baseline. If I can come up with a design of a study that would prove otherwise, I can prove that it actually is a risk factor, then what are we going to do? We will reject the null hypothesis. We can now say for certain that we are rejecting this null hypothesis, or the HO. Or, in other words, we're adopting an alternative hypothesis, or the H1. Okay? So, the basic question that you're starting off with is your hypothesis, it's the null hypothesis, and what you're trying to do with your research is to reject that null hypothesis. So, what is your question? How are we going to prove it or disprove it? That's what we need with our hypothesis. Okay? So what is our question? Our null hypothesis is that smoking is not a risk factor for amputation in patients with peripheral arterial disease. Isn't it? So that's our question. Does smoking cessation, if the patient stops smoking, decrease the risk of amputation in patients with peripheral arterial disease? That's our question. Okay, let's put that question in scientific terms. I'm still slowly reaching to the scientific term. I haven't reached to what I'm saying yet. This is what I want to say now. What's the question? If I give you these papers and I ask you what's the question, well, how are you going to find out the question? Does anyone know what this is? Pico. So when you're talking, when they tell you, go get a topic and come back, first question they're going to ask you, what's your hypothesis? What's your null hypothesis? What's your PICO? And PICO is very easy. Population, intervention, comparison, outcome.
This is the answer you need?
Yes. That is what they're looking for. They're looking for you to tell them what population are you going to work on? What intervention are you going to do? What are you going to compare it with? And what are the outcomes you're looking for? And that is the basis of research. If you know what your PICO is, it'll be much, much easier for you to start designing your study, because you'll be able to design based on, you know the appropriate design for your study. So what's our PICO, what's our population here? What's the population in this question? So patients with peripheral arterial disease. What's the intervention? Stop smoking. So smoking cessation. What's the comparison? So continue smoking. Okay, what are the outcomes?
Amputation. Yes.
Amputation. Easy. Life is very easy. Okay, so if you don't mind, 1, 2, 3, 4. And I'm doing this for a reason, because, so you can do it in groups. The reason why I'm trying to do this is because you need to be able to read as well. So if you look up any paper, the first thing you're going to look for, what's the null hypothesis? What's the PICO? So we'll start with this paper. Actually, did I give you the right one? I did, yeah. Yeah, so there is the aqueous and the other one is the alcoholic. Okay, so that's your I and that's your C. What's the O?
SSI.
Huh?
Surgical site infection.
Surgical site infection. So you can tell straight away from the very first paragraph or second paragraph of your abstract, and if you look further into the paper, at the very last two sentences of your introduction or the first two sentences of your objectives, you should be able to come up with your PICO. So when you're reading, how many here have done IELTS? How many here? Okay, so a few have done the IELTS. You know how to read in IELTS? You skim. In an article, if you're reading an article, don't read the introduction. You read the title, quickly read the abstract, forget the introduction. No, never the conclusion. Never the conclusion. The paper has already gone in the bin 10 hours before I've reached the conclusion. You read the last sentence in the introduction because sometimes objectives are there if there's no section for objectives.
The background.
And then you go to and then you go into the objectives, find out your PICO. Next thing, go to your methodology. So here we compared alcoholic chlorhexidine with aqueous chlorhexidine for skin antisepsis to prevent surgical site infection after minor skin incisions. So that's what we took out from there. That's the question. Is alcoholic chlorhexidine more effective than aqueous chlorhexidine in preventing surgical site infection following minor skin excisions in general practice? So our PICO, patients undergoing minor skin excisions in general practice, alcoholic chlorhexidine, aqueous chlorhexidine, and the outcome was surgical site infection. Okay, that one was easy. That was a trial. We're comparing treatment A to treatment B. How about observational studies? And there are 4 there, so if we can probably just... yeah. And we'll do this much quicker if we can. And we'll try and find out what the PICO is. And I'm deliberately doing this because sometimes you can get confused once if you're not sure. If it's not an RCT, if it's not a trial comparing treatment A to treatment B, it can be a little bit more confusing. So,
patients with cardiogenic shock.
So, P, patients with cardiogenic shock. Okay, before we go to the PICO, let's ask what's our hypothesis? Yeah, so there's no relation between the adrenomedulline and poor prognosis in cardiogenic shock. Are we comparing anything here? Do we have an I and do we have a C? Do we have an intervention and a comparator? So officially we don't. But if I look at, again, the end of the background or the objectives, so the aim of our study was to evaluate the prognostic value and association with hemodynamic parameters of bioactive adrenomedulline in patients with CS. So does it affect hemodynamic parameters in patients with cardiogenic shock? We've said this. So our intervention then is what?
Use of
There's no use. That's just that's a parameter. I don't even know what it is. I just picked up something.
As a marker.
If you look at it,
The marker level for this one.
it's a marker. Elevated bioadrenomedulline, because that is what causes the effect.
Comparison between hemodynamics and
And
all this one.
the comparison is normal level. So you're going back, looking at the ones who had high level versus the ones that had low level. I haven't given the patient any medication. I didn't do an intervention. But you're comparing those who had this to those who had that. And our outcome then is the prognosis in patients with cardiogenic shock and the hemodynamic parameters. We're looking at the hemodynamic parameters to see if they're worse in this group or that group. Okay? So if I'm going to go to the design, forget about what they've done. If you're just going to look at the PICO, what's the best way to test this? What study design would you do?
This one patient, another patient that sees outcome.
Prospective?
So you do a prospective study. One patient you'd put them on this, the other patient you'd use that. Okay? So you'll do a clinical trial, probably a randomized trial ideally, okay? But you're giving patient here something, giving patient there something else.
And another patient without.
Retrospective can be done as well.
Well, yeah, but I mean, we're talking what's the best way to answer that question, okay?
Cross-section. This will be cross-section.
You could do,
At the time of the cardiogenic shock, I will estimate this and I evaluate it.
absolutely right, okay? So here, am I elevating someone's adrenomedallin? No. All I'm doing is, I'm looking at patients who currently have cardiogenic shock, and I'm measuring their adrenomedallin. So, as Abdurrahman mentioned, this is a cross-sectional study. I'm looking at something at a certain moment in time, okay? Or I could go back and look if they had previous levels. Now, I don't know if this is something that can be looked at previously, then I could look at previous levels, okay? So, just by knowing that... Pardon?
Comparison. Like.
Yeah. So just by knowing the PICO, straight away you know that the design and the approach is going to be different. Can you do this as a randomized trial? No. What are you going to randomize them to? Okay? So just by knowing your PICO is starting to push you into a certain direction regarding your design. So we know what our question is. Then the next thing we need to know is, has it been asked before? Okay? You come up with an idea. احنا كلنا الحمد لله كمصريين عندنا حتة بس دي اتعملت قبل كده. أنا رحت له بتوبيك ما اتعملش قبل كده وهو يعني بص لي كده وراح رميها على جنب وراح مديني توبيك تاني منشور فيه 5000 بيبر قبل كده. السؤال ليه؟ Has it been asked before? Why? So if not, why not? ما ممكن يكون في سبب أصلاً إن هو السؤال غير منطقي على الإطلاق. We shouldn't even be asking it.
Practically cannot be.
And are there effective means to test it? We cannot, practically we can't really test it properly. And is it even a rational hypothesis or not? Okay? Whereas if it has been asked before, so if it's no, you can't find anything in the literature, but the answers to these is still that, well, actually, it's still a rational hypothesis. We now have the means to test it. We should go and do it. Yes, perfect. But if it's been asked before, then, at what level of evidence was the question asked? And if we replicate and resynthesize the study, is that necessary or is it even worth it? Sometimes, yes, they're looking at something from a different angle, and you're looking at it from a totally different perspective. Or, yes, it's been asked, but there's still not enough evidence in the literature, and you need to show your practice as well. So sometimes the fact that the question has been asked before is not necessarily a bad thing. So what we're going to do, we're going to search the literature. So that brings us back to what we said earlier on, the literature search. How are we going to search the literature? Does anyone know how to search the literature? احنا كلنا بنقول ايه؟ احنا انا بقرا وانا up to date وانا I search the literature and to some extent بقول ان انا عملت literature review واروح متلخبط في الكلام وقايل ان انا عامل systematic review يعني طيب يا ماشي اوكي قريت ازاي عملت ايه؟
Choose topic.
Okay, so you chose a topic,
Keywords for the topics first.
the keywords. So the keywords, there are mesh terms, medical subject headings. Okay? لأنه في حاجات أنا بدور على ischemia. If I search using the mesh term ischemia, it'll cover
Every
ischemia can be written I-S-C-H-A-E, can be written I-S-C-H-E. It'll cover probably peripheral arterial disease. It'll probably also cover a much broader area if it's too wide a term. But at least it'll cover most of them. So using mesh terms is important. Where can I find mesh terms? If you go onto PubMed and just key in the word that you're searching, and on the left just search for mesh terms. And it'll bring you the list of mesh terms that are available for that topic. If it's not there, you can still use certain keywords, but you have to come up with keywords that are relevant. But most importantly are these, the Boolean operators. Do we know what they are? You know them. You know, they just don't know the word Boolean. And, or, and not. So when we're searching, if I'm looking for peripheral arterial disease, smoking, amputation. Okay? The word and has a function. The word or has a function. The word not has a function. If I use or, اللي هي في النص دي, it'll get you everything. لو أنا عملت peripheral arterial disease or smoking, هيطلع لي ال 5000 بيبر اللي بتتكلم على peripheral arterial disease وسموكينج مع بعض، وهيطلع لي 90000 بيبر اللي بتتكلم على peripheral arterial disease لوحدها ما لهاش علاقه بالسموكينج، وهيطلع لي ال 500000 بيبر اللي بتتكلم على السموكينج لوحدها ما لهاش علاقه بالperipheral arterial disease. فit'll get you everything if you use the word or. في حين ان انا لو قلت and peripheral arterial disease and smoking هيطلع لي اللي بيتكلموا على النقطتين دول بس. Okay? So using the and or the or makes a difference. So peripheral arterial disease between brackets زي ايه الحساب بتاع زمان 5 زائد 6 between brackets و x زائد y between brackets وعلامة ايه في او divide في النص ما بينهم. فانت peripheral arterial disease between brackets هقول بقى peripheral arterial disease وهقول مثلا peripheral arterial disease or critical limb ischemia or claudication. كل الحاجات اللي ليها علاقة بالperipheral arterial disease أنا عايزها or كل دول between brackets. والناحية التانية smoking or smoking cessation or nicotine replacement therapy ما بين brackets. وفي النص هروح حاطط and. Okay? وممكن استعمل not ان انا عايز مثلا peripheral arterial disease not smoking او بلاش smoking not peripheral arterial disease. هيطلع لي كل البيبرز اللي بتتكلم على السموكينج اللي ما فيهاش سيرة peripheral arterial disease من اساسه. اتكلمت على كل السموكينج اللي في الدنيا اللي بعيد عن peripheral arterial disease. انا عايز ان انا exclude البوبوليشن بتاع peripheral arterial disease في الستادي بتاعتي. فهسيرش على smoking not peripheral arterial disease. So your mesh terms are very important. Using keywords, but in between, these are extremely important. So when you're doing a literature search, you're doing a literature search using your Boolean operators, and make sure you do it right. There are a few limitations that you could put in. You could limit according to study type. You could limit according to publication date. أنا مش عايز اللي قبل 2005 مثلا، لأن قبليها كان الناس بتعمل حاجة الميثودولوجي كانت totally different. You can limit according to language, so you can put your limitations as much as you want. When you're searching, where am I going to search? Are we going to search Google? You actually can, but if you're going to search Google, use Google Scholar. Don't use Google, general Google, okay? You've got loads of options. The most common one, and is free and available for everyone, is PubMed. Okay. The rest of the databases, the Ovid, the EBSCO databases. So underneath Ovid, you've got Medline, Embase, AMED, which is the Allied and Complementary Medicine database. The problem with these is that most of them would be available for free within a certain institution. So you might be lucky if the HSC library has access to one or two of them, probably not all. If you're working close to a university, so most of the universities would have access to these databases. One of the things that ideally, if we had enough money within the group here, إن احنا نحاول إن احنا يبقى لنا احنا نفسنا access to these, it would be ideal because it means that you can do research and you're not limited to the universities. أنا بالنسبة لي الوضع سهل. أنا through NUIG, but yeah, I have full access to these. But each and individual one of us, it becomes extremely difficult. The Sinhal is more related to kind of nursing topics, but you have to remember that there is a lot of crossover between medical and nursing literature. Scopus is great to get also ideas about your own work or even the citation of work. So if someone has published in a certain topic, where was that article cited? And that in itself is very important, because when you're looking for something in the literature, the terms that you put in to search might get you a certain paper. Well, this looks good, it looks relevant, but you find that it's cited somewhere else. Your search didn't get that other article, but that other article is actually extremely important. So the Scopus is good in that it gives you a bit of an idea about citations as well. One of the other things that's good for citations is Mendeley, but Mendeley you can't really search properly for within Mendeley. Within Mendeley, it's probably a tool for yourself that you know what your own citation is like, what your H index or your publication index is like. So if you're going to search, these are the tools that you have. Okay. لغاية دلوقتي كل اللي احنا عملناه ان احنا اتكلمنا على question, how are we going to search? That's all we've done. So we need to start moving on. Let's actually do research. Let's do something. Okay. So how will you answer your question? How will you assess your intervention versus the comparator? Two questions you need to ask yourself. What type of data will you need to use? And what's the appropriate study design? What types of data are there? What are the two broad kind of types of data? Qualitative and quantitative. Exactly. Okay? So, could be qualitative, could be quantitative. Interviews, surveys, certain observations. الناس بتوع psychiatry بيحبوا الحاجات دي جدا. Quantitative, actual quantifiable data, numbers. How many men, how many women? That's quantitative. And it's much easier to do statistical analysis with quantitative. Unfortunately, I won't be in a position to help anyone with qualitative data. I hate it. I don't know anything about how to do statistics for qualitative data, and I don't intend to know anything because, alhamdulillah, all of my work is quantitative. Much easier. So then, once we know the type of data, and we'll probably focus more on the quantitative, because that's where most of our work is going to be, unless we have a psychiatrist in the room. I don't know, do we have a psychiatrist in the room? No. So, نتكلم براحتنا. Quantitative. So what is the study design that we're going to use? Different types of study designs. We've already talked about the different levels of evidence. And down here, we already have our case report, our case series, which is more descriptive. You probably won't do much statistics with that. If you want to start to do an observational study that is analytical, you've got the cross-sectional, the case control, and the cohorts, and then the actual experimental, the trials, randomized controlled trials or non-randomized controlled trials. I'll quickly run through them so that we don't waste time, but just to give a few examples. Case report, you're reporting on a single case. Simple as that. Okay? بما ان الشباب بتوع جولوي هنا فحطينا بيبر من بتاعتنا talking about a single case. Aortic cable fistula, how we managed it endovascularly fully. And that's it. What's the difference between that and a case series? A collection of reports on the treatment of individual patients. 10 patients. Okay? Sorry. Yep.
حتى لو أكتر من 10 ممكن أبقى كيس.
Yeah. But you're not comparing anything.
But within the same
Yeah.
patients.
Yeah.
A patient with the same characters, I'll say those same characters have these and that.
Yes, that's it.
Yeah.
That's it. That's a case series.
Yeah.
Okay?
From 1 to 10.
No, a case report is 1 to 10. More than 10 is a case series.
More than 10.
Yeah, 10 or more is a case series.
But what is the difference with prospective? Prospective study was like 50 patients, like.
You're not comparing anything at all. Yeah, you're just saying, مثلا, we had 15 difficult cases that we treated them in this part, or presented in this particular manner, and we treated them all in the same way, and that's it. Full stop. And there has to be a reason for you to even report on that. That these have to be unusual cases. If you're at the stage where you're getting 50 patients, why are you even reporting it? There should be standard practice, there should be guidelines. Why are you even reporting this? Okay? Unusual cases. An unusual case, 1, 2, 9, that's fine. But 10, okay, case series, 15, 20. Beyond that, you're talking about, there's no point in even reporting them as a case report or a case series.
Just a little announcement. Just
Yeah.
sorry to interrupt. السيشن الثانية بتاعت الانترفيو ان شاء الله تبتدي الساعة 4:30 يعني كمان 5 دقايق. في كوفي وتي وفي مية اللي عايز قبل الانترفيو كورس. في 8 candidates ان شاء الله في الانترفيو كورس اللي هي السيشن الثانية في الأوضة اللي هي أول أوضة على الشمال بعد الكوريدور. تمام. الحاجة الثانية بس الباركينج ان شاء الله لو كل الناس راكنة في الأوتيل في تخفيض تدفع 6.5 يورو بير داي، ده يغطي اليوم كله. فان شاء الله بس لو حد راكن بره او بيدفع اكتر من كده يقول لهم بس ان هو تبع اللقاء بتاع وجزاكم الله خير. شكرا.
هو لو كده بقى نستأذن الناس اللي هتبتدي في الكورس تتحرك، لان هي يعني هي اوريدي الست يعني ما تبقاش مبسوطه لما الناس بتتاخر يعني.
اوكي معلش كله عارف المكان فين؟ في الاوضه بتاعت الانترفيو كورس. توفيق ان شاء الله. في كوفي بريك ممكن تاخد 5 دقايق لو عايز.
احنا عايزين نفوق ونكمل واحنا
That's
فايقين.
fine. Yeah,
لو
absolutely.
5
Yeah,
minutes بس
yeah,
نشرب
no
قهوة.
problem.
لان الناس
الموضوع فعلا
Yeah.
هنروح
فممكن
Yeah.
ممكن ناخد
That's fine. Yeah. يا دوبك ابتدينا نتكلم على the different types of studies or different study designs. So the first thing we mentioned was the case reports and the case series. And then we're moving on to cross-sectional studies. So out of our observational studies, we've got cross-sectional studies, we've got case control studies, we've got cohort studies. Cross-sectional studies, these are the studies that we use to get prevalence. So it's a snapshot in time. A certain specific point in time, we look, we see what's going on, and we're neither going retrospectively nor prospectively. We're looking right now. So it analyzes the data collected from a population or a subset of that population, or usually a representative subset of that population, at a certain specific point in time. So it gives us prevalence. One of the examples is this one, the annual report to the nation on the status of cancer between 1975 and 2014, featuring survival. This is an annual report in the US on prevalence of different types of cancer and survival from cancer, and it's done every single year. So if you open this and look it up, they're not going to go back and say, from 1975 to 2014, there were this many breast cancers. The way they will report that as a cross-sectional study would be, 1975, this much percent of the female population had breast cancer. 1976, this much percent. 1977, this much percent. That's what they're doing as cross-sectional studies. The census of a population, that's a cross-sectional study. So one of them is at a certain point in time, right now, which is the cross-sectional. The next one, which is case control, is retrospective. You're going backwards to see what's going on. And then a prospective observational study is a cohort study. Case control studies. What you need for a case control study, you need a case, you need a control. So you're looking at your individuals, the patients that are involved. The case, اللي هم الناس اللي عندهم a specific disease or condition. Control, those that don't. And then you're going to go backwards. هنبص على العيانين دلوقتي اللي عندهم cardiogenic shock واللي ما عندهمش. And then I'll go backwards. مثال, relationship between the use of conjugated estrogens and the risk of endometrial cancer. What they've done here, they got cases, females that have endometrial cancer. Controls, those who don't have endometrial cancer. The exposure was the exposure to conjugated estrogens, the use of conjugated estrogens. So what they did is they went backwards in time. They looked at the case patients, they looked at the control patients. What was the prevalence of conjugated estrogen use here? What was the prevalence of conjugated estrogen use there? And that's how they got their outcome. And their outcome was the use of conjugated estrogens was higher in females that have endometrial cancer than those who do not have endometrial cancer. So you're going backwards and trying to say, well, probably that was a risk factor for them developing endometrial cancer. Okay? The example we gave earlier on about the cardiogenic shock, the patients that have adrenomedullin, which type was it? I'll leave that question. I actually have it later on. We'll leave it, but think about it for a second. So we'll move on then to the prospective one, which is the cohort study. We're still observational. We're not randomizing patients, but I'm going to look at patients or people now and follow them up for a period of time and then look at certain outcomes. So I'm going to identify a group of patients who already have a disease or take a specific treatment. And I follow them over time, and then I compare their outcomes to a similar group without the disease or treatment. The most famous study of those is the Framingham study. حد سمع الفرامينغهام study؟ أو عارف بتتكلم على إيه؟ Framingham study is the study where the evidence of risk factors for cardiovascular disease started. دي الستادي اللي قالت لنا إن smoking is a risk factor for cardiovascular disease, hypertension, diabetes. This study started in 1948 and it's still running till today. قوم في سنة 48 وراحوا إيه في بلد في أمريكا اسمها فرامينغهام. They consented the whole town that they will follow them up for their entire life. And they have since consented their offspring, so the sons and daughters, and now they have consented the grandsons and granddaughters. And the study is still running. هم جابوا ناس وقالوا we'll follow you up. Every 2 years we'll bring you for a checkup. And what they're doing is, okay, so these patients have peripheral arterial disease, these don't. These patients have myocardial ischemia, these don't. These are smokers. So we'll follow the smokers up. Smokers develop this, that. Non-smokers didn't develop this, that. And that's how we came up with risk factors for cardiovascular disease. The problem with cohort studies is that it takes a huge amount of time to get anything meaningful. And that's why, although you're not randomizing, you're not doing anything, it's still level 2 evidence because of the amount of work and effort that goes into it. You can move on then to the experimental studies. So the 3 main studies that are non-experimental, observational, the one that's looking right now, cross-sectional, the one that's looking back, case control, the one that's going forward, cohort. But then the experimental studies, the main one is randomized controlled trials. So you're going forward, but you are giving group A treatment A, group B treatment B. So you're randomizing them to an intervention and a control group. That's very, very like our PICO. It becomes very easy. You know your population, you know treatment, your intervention group, you know your comparator group, and you know what your endpoints are. It becomes easy. Okay? Now, controlled trials, the ideal scenario would be randomized controlled trials. But we don't always have the luxury to randomize. We might have to just assign. And if it's a case control study, it's not a level 1 evidence. It goes down to probably a level 2. So without randomization, the level goes down. Other things when it comes to conducting a study as well, is it blinded or not? We hear the word blinded or double-blinded. How many here has read the word blinded or double-blinded? What's blinded, what's double-blinded?
Blinded, that means the patient doesn't know what's the treatment, but double-blinded, even the applicator of the treatment doesn't know what's the treatment.
Okay, very good. So, blinding, the patient doesn't know what they're getting, if that's single blinding. بالبلدي. Single blinding, the patient doesn't know. Double blinded, the patient and the physician don't know. رسمي, ما فيش حاجة اسمها single blinding or double blinding. If you're actually going to report something and say blinded or double-blinded, you have to specify who is blinded. Right now, you probably won't even get a paper published if you mention the word double-blinded. They throw it back. Blinded, you have to, because you could blind the patient, you could blind the administrator, as in the physician who's administering the medication. You can blind the assessor, because not always the administrator is the assessor. So you have delivered a certain medication to the patient. It comes in a box. You don't know what is that medication, or is it placebo. But then the patient comes to follow-up in your clinic, and they're seen by somebody else, an assessor. That assessor might actually know, is that patient on placebo or is the patient on the actual drug. So the assessor themselves have to be blinded. The statistician has to be blinded. So rather than using the word single, double, treble, quadruple blinding, you have to say who is blinded. Yes, blinding, it would be ideal. And you might have heard of the word bias, risk of bias. If you're not blinding, you already have an inherent risk of bias in your study, and it decreases the weight of your study. But there are things where there's no way you can blind. We're doing a patient with coronary stenosis. You're either going to do coronary angioplasty and stenting or a cabbage, open surgery. Can you blind the patient? The patient obviously knows what's been done. Can you blind the surgeon? Can you blind the assessor? You just can't. You physically can't. So sometimes you just cannot blind, and you have to justify why you didn't blind. Even though it goes without saying, you still have to make a note in your manuscript why you didn't blind. So that's the easiest one, medication versus placebo in the management of whatever. That's our most simple form of a randomized controlled trial. The next one, which is level 1A, which is systematic review. Systematic review, اللي احنا قلنا بقى من الأول إن هي ما هياش literature review. Systematic review is something else. Systematic review, you are collecting all the published data in a specific topic. So you're doing a summary of the clinical literature. طب ما هي دي ما أنا قريت ما أنا عملت summary of clinical literature. لا. There's a systematic way of doing that. You are going to first search for all papers in the literature that cover your PICO, that cover your question. So your search strategy has to be appropriate from the start. كل الكيوردز اللي انت بتستعملها, you have to make sure that you have got every single paper ever published في الموضوع ده to include it. To the point, ان انت لو if you have published a systematic review on a topic, and I have published in that topic something relevant, and you haven't included my paper, I won't contact you. I will contact the editor of the journal and ask, why was this paper not included? And they will get back to the authors and ask the same question. They have to have a very, very valid reason as to why my paper was not included. The fact that it was missed is not a valid answer. And that in itself could be a reason for it to be thrown out. Even one paper, even a single paper. So your search strategy has to be correct. And then there's a way of going through the published papers. You'll go through the titles. Well, the title is not appropriate because sometimes you'll get excessive papers that don't specifically answer the question that I'm asking. The next step, you'll go through the abstracts and read the abstracts. and make sure that the methodology is correct, that the population is correct. Because sometimes I might be looking for something, a specific treatment in a specific disease. But your paper was looking at that specific treatment for that specific disease in patients with Marfan syndrome, for example. That's far away from the population that I am looking at. It's not representative of the population. So I can justify why I rejected your paper.
It's not easy.
It's systematic review. To do a proper systematic review, you would take from start to finish somewhere between 1 to 2 years. Yes?
Just sorry.
Yeah.
So, in systematic review, if I say that I will search in PubMed, in Orbit, in this, Cochrane's, and so I have done this, and I found there's like 5,000 articles. My inclusion criteria is 1 and 2 and 3.
Yes.
And my exclusion criteria is 3, 4, 5.
Yes.
Not in English language, not in that, not in that.
Although-
so nobody can catch me and say, why you didn't. I said, you are not in this inclusion or conclusion.
Only if my article actually meets your exclusion criteria.
Yeah, that's what I'm saying. That if I have a proper exclusion criteria, nobody will catch me because I know what I'm picking up.
If you have a proper protocol.
Yeah.
Okay? So you need, for your protocol, to write a systematic review, you need to know first what your PICO is exactly. Do your search strategy. Make sure that you have proper, like you said, inclusion and exclusion criteria for the articles. Meaning that I will exclude articles that have a population under the age of 18, all peds. I cannot turn around and say then, why didn't you include my paper? Because although my paper is reporting on peds. Or I will exclude papers that are not specifically reporting on this particular outcome in this particular manner. That's fine. But the problems happen when you miss a paper that actually meets your inclusion-exclusion criteria, that should have been put in. And that is the problem. And 5,000, by the way, is you're being kind of very optimistic. You usually end up with somewhere along the lines of about 10,000, 30,000 sometimes, 40,000 sometimes.
If I specify, like, I have one
Yeah.
research like that, I say I will search for certain words like 1, 2, 3, and I will not search for 4 and 5 and 6. And that's why I found, and then I say I will get the evidence 1 and 2, accept level.
Absolutely. You see, it's all what you make it. It's all what you make it. For example, one of the biggest examples of systematic reviews is Cochrane reviews. Okay, to do a Cochrane review, they give you 3 months to do your protocol, depending on which area. So in vascular, they give us 3 months. In other areas like stroke, they give you a full year just to write the protocol. Why? To make sure that you're getting it right. Because once you have put your inclusion-exclusion criteria, you cannot go back. So I could do a systematic review of randomized controlled trials. So in your inclusion criteria, they have to all be RCTs. If I have published a cohort study, then that's it. You're not included. It's as simple as that. But you have to set the rules from the very, very, very beginning. And then even there's a process for it. So there's 10,000 articles, titles that we got. The 10,000 titles, it's not that I'm going to go run through them myself on my own. There has to be a minimum of 2 people. You read through the 10,000 titles, and I'm ticking accept, accept, reject, and so on. And someone else is doing the exact same thing independently. And then we sit together and go through them. Well, I accepted this, you accepted this, move on. I rejected, you rejected, move on. I accepted this and you rejected it. We have to discuss why. And then if we can't reach to an agreement, then we get a third person, usually the most senior person in the team, to look at it and decide if we will include or exclude. And it's not a matter of يا عم خلص بقى يعني ما جتش على دي مشيها.
This is the best solution.
You actually can't. Because in your appendix at the end, you have to have, like within a systematic review, you'll put your, let's say 10 papers that were included, and you put the data and all of that. But then in your appendix at the end, you will have the references for the 10,000 articles that you got and you rejected as titles. And how many of those were rejected as abstracts, and so on. So it's way more difficult than you think. You have to be 100% sure that you have included properly or excluded properly. And when it comes to systematic reviews, you amalgamate the data. So Abu Shanab et al. Has reported on 1,000 patients, I don't know what, 1,000 patients who survived, let's say we're talking about survival after, I don't know, an OGD. They're very bad at doing OGDs, so we gauge it by survival. So their 5-year survival post whatever was 80%. And whoever et al. Their 5-year survival was 70%, and whoever et al. Their survival was 60%. 1,000 patients here, 1,000 there, 2,000 there. So what we do is we amalgamate 2 and 1 and 1, so that's 4,000, and the overall survival in those 4,000 patients was this much. That's as much as you can do with a systematic review. You amalgamate the results, and you can only do it if the results are reported in a similar manner. So if I'm let's say checking if the patient had an MI, and I'm checking the MI through troponin levels only, and someone else is checking a myocardial infarction through troponin levels and ECG changes, and another person is doing them only if they're symptomatic, your population is different. You can't add them together. But you say that you've gone through them, but you couldn't do the maths because the population was different. Okay? The next step then would be a meta-analysis. It's exactly the same as a systematic review, but you would be able to pool the data even further. So for the systematic review, you had a crude idea of the data, but now you have the raw data itself. You can actually go through, do what we call a forest plot, and get proper data from the original data. So I would be contacting Dawood et al. And asking for basic data, the crude data itself, in order to do a meta-analysis. All right, so very, very quickly, you still have the papers around.
Dr. Wael,
Yes.
Then I'll wait all 20 minutes.
Okay, that's fine. If we still have the paper there, can we, yes?
Can I ask, for the previous point, there should be, it can be essay, like for you are collecting data only, or so it must be work like practical on cases, like case studies you have?
No, you can do a systematic review or meta-analysis for anything. You can do it for randomized trials, you can do it for cohort studies, you can do it for qualitative studies, but the methods obviously will differ according to the data that you're dealing with.
There shouldn't be work on cases. You can collect data and you get a new result.
Yes, absolutely.
Can I limit this for last 5 years?
You can, but you have to justify it. You have to be able to justify it. So even limitation according to language, you have to be able to justify it. So for example, for us, if I'm doing something on aortic dissections, if I limit it to the English literature, the highest incidence of aortic dissection and the highest publications in aortic dissection are from China.
So it can be Chinese, so you cannot...
If you limit it to English, straight away you'll be asked, why did you limit it to English?
Oh.
You have to. You have to get either a proper justification
you
or...
can mention, but I can mention, but that it's in Chinese language, so we cannot add it.
No, you have to get them. That's why it takes 1 to 2 years
Wow.
minimum.
So you have to learn other language.
Or either get someone on your team who can translate, or at the very minimum get Google Translate to use it. And it's a valid thing to say for the abstract and the titles. And then when it comes to the actual thing, you try and contact someone, and there's a cost involved, because there will be a cost involved in that. Okay, so just so that we don't waste time, the first study that we looked at, what type of design was it? The alcohol versus the aqueous chlorhexidine, the one on the minor surgeries.
Control trial.
So it's a controlled trial. Okay. So if we look here, they said what? We conducted this prospective, multi-center, randomized controlled trial. So it's actually a randomized controlled trial. Okay. We randomly assigned to undergo pre-operative skin antisepsis with this 70% ethanol, which is our I, or 0.5% chlorhexidine, which was our C. You see how they're spelling it out? What's our intervention? What's our control? So your PICO, even when you're writing, you have to make it clear. You have to spell out your PICO. Okay? What about the next one, the other paper? The adrenomedulline in cardiogenic shock. Abdurrahman has already told us. It's cross-section. Because we're looking at patients with cardiogenic shock now, and we're looking at the level of the adrenomedulline. If we were, let's say, looking at patients in cardiogenic shock versus patients who are not in cardiogenic shock, and we go backwards in time to check, for example, if, let's say, I don't even know what adrenomedulline is, by the way, but let's say adrenomedulline is something that is routinely tested, and I were to go back and check their adrenomedulline level from 1 year ago, then we have shifted from cross-sectional to case control. Okay? So right now, this point in time, so it is cross-sectional. And again, in your methods. Now, so they're saying it was a prospective observational cohort study. Okay. This is different now. In this sub-analysis, serial plasma bio-ADM and arterial blood lactate measurements were collected from 178 patients during the first 10 days after detection of CS. Always be careful and do not be fooled by what is written. You will find things reported as, oh, this is a cohort study, or this is a whatever study, but it's not.
Maybe wrong.
They're playing with words. Card shock, the ISMA study, ISMA trial, was a prospective observational European multinational cohort study of cardiogenic shock. Yes, card shock itself was a cohort study, a prospective cohort study.
Not this study.
بس هو عامل sub analysis. هو عامل دي prospective study, prospective cohort study ان انا هجمع العيانين اللي هيجي لهم cardiogenic shock. ما انا اكيد مش يعني مش قاعد دلوقتي الم يعني هو في 10 cardiogenic shock قاعدين قدامي يعني فانا I'm prospectively designing this to collect the cardiogenic shock patients. So this, the initial paper, مش دي, was a cohort study. في حين ان الجزئية دي بالذات on its own is a different thing. That's a cross-sectional study. So if this were done on its own, that would have been a cross-sectional study. So عشان كده بقول it's a matter of if you know how to write, you know how to read. If I were critiquing this patient, let's say طلع في الجورنال كلاب وبتقدم paper في الآخر بيقول لك critique it. هم بيدعوا إن دي cohort study بس علشان كذا وكذا وكذا. It's actually not. Yes, it's a sub-analysis of the cohort study, but in this particular instant, it's not. أهم حاجة بقى. We know what our question is. We know how we're going to test it. We know our study design. We need to start reporting. So we'll report our outcomes Okay, what are our outcomes? What are our endpoints? حضرتك دكتور ENT. اوكي؟ هو احنا لما بندخل نعمل procedure مش بنمشي على الخطوات 1 2 3 4 يعني الخطوات دي مكتوبة. احنا برضو لما هنكتب هنمشي على الخطوات 1 2 3 4. لما present هنمشي على الخطوات 1 2 3 4. لما هتروح مؤتمر تسمع هتلاقي ان هم بيتكلموا كلهم بيقولوا نفس الاسطمبة. عندنا في مؤتمرات بتاعة الفاسكولار اي حاجة peripheral our first primary endpoint is amputation free survival. amputation free survival measured as
the decision you mean?
Huh?
Outcome as a decision?
No, outcome as in how are you reporting your results? What's the most important result? What's your main endpoint? Sorry, I don't know what happened there. Okay? So we have reporting standards for endovascular aortic aneurysm repair. I'm giving you examples from vascular. كل حاجة عندنا في الفاسكولار متحددة. الend points بتاعتك عبارة عن 1 2 3 4. أنت you're doing something on abdominal aortic aneurysms. You have to report on this. So you have to report on the baseline characteristics of the patients. You have to report on what procedure did you do. So and when you're reporting on the procedure, which parts of the procedure that do you have to report on, and the outcomes. How many survived within the first 30 days? Your operative complications, your endo leaks, your sac expansion, everything. It tells you what you have to report on. And the minimum reporting standards, meaning that you shouldn't be reporting any less than these. واحدة تانية. Reporting standards for the SBS Society for Endovascular Treatment of Chronic Lower Extremity Peripheral Arterial Disease. ففي peripheral arterial disease 1 2 3 4. طب ماشي احنا الناس بتوع الفاسكولار ناس منظمين وناس كويسين والدنيا سهله. حاجات انا ما اعرفش اي حاجه عنها. Adverse event reporting in patients treated with thyroid hormone extract. So if you're going to be doing a study on thyroid hormone extract, there are certain things that you have to report on. Minimum reporting standards for clinical research on growing pain in athletes. هتعمل study على الاثليتس اللي بيجي لهم growing pain. هتكلم عليها ازاي؟ What are the steps? What are the points you're going to mention? Extremely important that you know what the reporting standards are before you even collect the data. We have designed our study and you want to start collecting the data. طب انهي data بقى اللي collected وازاي؟ based على reporting standards. So you need to make sure that what your primary endpoint is, try and keep it as simple as possible. If you're designing a prospective study, you need to do what we call a power of the study. أنا محتاج كم عيان علشان الstudy دي تديني significant outcome, تديني significant result. So دي بتبقى based على primary endpoint. So try to make your primary endpoint as simple as possible. And then your secondary endpoints, make sure that you cover المينيمال requirements اللي موجودة في reporting standards. Okay? وحاليا معظم الستاديز لو هتعمل حاجة prospective محتاج ان انت تتكلم على quality of life لازم تضيف quality of life endpoint ولازم تتكلم على safety endpoint.
So these standards should be applicable in each study. I can pick it according to the topic.
Exactly. أنا هدي مثال واحد بسيط لما بنتكلم على مثلا إيه أنا هريبورت البيز لاين أنا بقارن جروب A بجروب B. البيز لاين بتاعنا هقول ان عايز اقول الاثنين كانوا زي بعض والاختلاف الوحيد كان من التريتمنت اللي اديته ده او اللي ده. فبريبورت كم واحد كان عنده هايبرتنشن، كم واحد كان دايابيتك، كم واحد كان سموكر، كم واحد كان مش عارف ايه. طيب اوكي ويل اند جود، انت هتجمع الداتا دي ازاي؟ هل انت هتروح قايل مثلا ايه دايابيتك نون دايابيتك، سموكر نون سموكر، هايبرتنسيف نون هايبرتنسيف، ولا هتعمل ايه؟ لا. According to the reporting guidelines, diabetes is 0, 1, 2, 3. Hypertension, 0, not hypertensive. 1, controlled with 1 drug. 2, controlled with 2 drugs. 3, requiring more than 2 drugs. Now, This is important in vascular, that these risk factors that you actually elaborate. Probably in ENT, it makes no sense whatsoever. I don't know. But you will have other things where it tells you you have to specifically report in this way. So you know when you're collecting your data, how are you collecting it and why are you collecting it? Okay? I'll quickly skim through. احنا اتكلمنا على different study types. اتكلمنا على الcohort, اتكلمنا على case report, على case control, اتكلمنا على systematic reviews والmeta analysis. طيب انا دلوقتي عرفت انا ايه الداتا اللي انا محتاج ان انا اجمعها based على الريبورتنج ستاندردز. انا عايز اكتبها بقى. وعايز اتاكد بقى ان بعد الهم ده كله انها تبقى published. ما يجوش بعد ده كله يروح يرميها لي يقول لي انت ما عملتش حاجه. مع ان انا ماشي على النظام مظبوط. في ريبورتنج ستاندردز ازاي تكتب. لو انت هتعمل observational study سواء كانت cohort او cross sectional او case control في حاجه اسمها strobe statement. The strengthening the reporting of observational studies in epidemiology اللي هو strobe guidelines. ودي بتدي لك تشيك ليست. انا عندي هوريه لكم يعني بس يعني تشيك ليست وانت بتكتب اعمل تيك انا عملت كذا ما عملتش كذا. Same thing. If you're going to do a randomized trial, you have to follow the consort statement. اللي هو guidelines ازاي to report randomized controlled trials. لو هتعمل systematic review, you have to follow the PRISMA statement. لو هتتكلم على الايه الcost effectiveness, هتعمل حاجه اسمها cheers statement. فدي التشيك ليست انا حاططهم بس كده ايه بس يعني you can quickly have a look at them. هتلاقي ان الدنيا بسيطه جدا.
هي open access الحاجات دي.
دي موجوده دي available يعني انت لو اعمل حتى بالك جوجل سيرش عادي ستروب ستيتمنت هيطلع لك الويب سايت بتاع الستروب ستيتمنت وتحتيه في داونلودز including التشيك ليست. والتشيك ليست هتلاقي الحاجات ايه بيتكلم التايتل والابستراكت يتكتب فيه ايه وازاي.
You can choose one or you have to do all.
No, you have to do all. This is a checklist. Tick the box. Make sure you have done everything. You have to tick the box.
You have to do each one.
لا لو انت مثلا الستروب دي بتاعت observational study. لو انا بعمل observational study هستعمل الستروب. لو انا بعمل control trial هستعمل الconsort.
Each one related.
بالظبط. فهستعمل specifically نوع الستادي اللي انا بعملها وهو بيقول لك tick the box. الانترودكشن كتبت فيه ايه؟ الاوبجكتيفز كتبتها بالطريقه الفلانيه، الميثودز لازم تكتب الترايل ديزاين، البارتيسيبنتس، الانترفنشن، الاوتكم. هو اوريدي حط لك ايه؟ البيكو هنا، السامبل سايز، الراندومايزيشن. كل الحاجات
that you satisfied all the
exactly. ونفس الحكايه في البريزما. وانت لما بتيجي تكتب لازم هتقول ان انا I followed the strobe statement guidelines. اوكي؟ انا خلاص هأسرع دلوقتي عشان نخلص. انا عارف الداتا اللي انا المفروض اجمعها هستعملها ازاي او هعمل لها اناليسيز ازاي. هتجمعها ايضا على اكسل شيت او على statistical software زي الاس بي اس اس. انا شخصيا بستعمل اس بي اس اس لان بحس ان هو اسهل انك تعمل data analysis using it. It's very easy. لو هتستعمل داتا النصيحه الوحيده اللي هقولها لك جمعها numerically. ميل فيميل، ما تكتبش ميل ما تكتبش فيميل. 0 1 دايما 0 1. 1 is usually the event. ف amputation يبقى الايفنت واحد يبقى amputation واحد، no amputation 0. ومع كامل اعتذاري الايفنت 1 فالميل 1 والفيميل 0 فمعلش عذرا دي يعني. هي كده هنعمل ايه بس؟
دي ستاندرد يعني
دي ستاندرد. هي ستاندرد.
مش عشان المصريين
كده عندنا مشكله.
انواع الداتا يعني ازاي هتعمل لها statistical analysis. احنا ما عندناش وقت ان احنا go through statistics بس at least تبقى عارف ان في 3 انواع من الداتا، الكونتينوس داتا، الاوردينال او الكاتيجوريكال. كلهم هيبقوا ارقام بس الارقام بتختلف. الكونتينوس داتا دول اللي هي ايه؟ الايج، الويت، الهايت. الرقم واحد عنده 77 سنه الرقم معناه 77، ذاتس ات، ما فيهاش اختلاف. في حين ان الاوردينال هم ارقام برضو، بس 0 1 2 3 4 in a certain order in certain hierarchy، زي مثلا TNM classification او ال ASA grading، الحاجات اللي هي different class where number 2 is worse than number 1. اوكي؟ categorical اللي هي الارقام اللي احنا لسه قايلين عليها، male female 0 1، dead alive 0 1، amputation 0 1، اللي هي الباينري داتا. وممكن تكون multiple categories. طب انا حاطط age تاني هنا عشان الخبطكم. age دول categories مش كده؟ انا عامل مجمع 0 اللي هو age اقل من 50، واحد من 51 ل 60، 2 من 61 ل 70، 3 فوق ال 70.
This should be added in the
فوق
and then you can use it
في الهيد بالظبط. فانت يعني انا هنا مش مستعمل الايج كل واحد بالايج بتاعه، انا مستعمله ايه؟ كل واحد منفصل.
هو الجندر لسه باينري؟
دخلنا
احنا مجتمع مصريين. مجتمع مصريين. عملت الشغل ده كله، عايز بقى انك ايه؟ تببلش. لازم نبتدي نكتب. قبل ما تكتب انت عارف هتكتب ازاي وفولود الجايد لاينز. هتببلش فين؟ وحدد هتببلش فين من قبل ما تكتب. لو انت هتروح، انت ممكن تببلش في جورنالز، في كوكران لايبرري. احنا ممكن هتروح تبريزنت في كونفرنس، الطريقه اللي هتكتب بيها هنا غير هنا. اوكي؟ ممكن ان انت هتروح تدي محاضره لاكسبرت جروبس. Target a journal. Think of the impact factor of the journal. The higher the impact factor, the better the journal, the better on your CV, the more difficult it is for them to accept your paper. الريفيو بروسيس بتاعهم اصعب كتير. فبي very careful. لو انت عندك شغل تقيل, aim for the highest. Even if they reject it, they'll reject it with critique. You'll do it and then go for the next one down. قبل ما تبعت لهم, خش على الويب سايت بتاعهم, follow their instructions for authors. كل journal ليهم instructions مختلفة. الجورنال اللي كاتبالك انك تستعمل فانكوفر في الريفرنسز وانت رايح بتستعمل البي ام جي، من قبل ما هيعملوا حاجة ارجع. فول ستوب. واحتمال كبير انه يقول لك ما ترجع لناش تاني. اعرف انت بتكتب ازاي. الكفر بيج هتكتب فيه كل الحاجات دي. انا بس عايز اقول النقطة دي مهمة جدا، عشان احنا في مصر الحمد لله احنا عندنا عادة حلوة كده
نفسنا
ان الكبير اسمه بيتحط اول واحد. مفيش حاجة اسمها كده. الفيرست اوثر الشخص اللي بيكتب البيبر. ممكن يكون الشخص ده ما عملش حاجة في البيبر من اساسه غير انه كتب البيبر. اللي كتب البيبر هو الفيرست اوثر. عادة المفروض يعني اللي يحصل ان الشخص ده يكون ايه؟ عمل كم داتا وي وهو الفيرست اوثر. اوكي؟ المفروض انا كنت عايز بس دي اللي تبقى حمراء، معرفش الباقي عمل كده ليه يعني. اللاست اوثر هو الموست سينيور اوثر. When they're looking at publications, they look at the first name and the last name. There might be a joint first author, but you have to indicate it when you're submitting. Okay? وكل ما الأسامي بتزيد التاني أقل في الأهمية من الأول، التالت أقل في الأهمية من التاني، وهكذا وهكذا. First is the most important and the last. الاثنين نفس الثقل.
اللي في النص بقى دول.
أنا هديكوا بس يعني مثال بسيط، أنا مش عايز أطول عشان أنا عارف إحنا خلاص خلصنا، بس مش عايز أطول. أول ما جيت هنا أنا اتسألت سؤال. Who is أحمد شفيق؟ I think كلنا نعرف في الجراح الكبير أحمد شفيق. Who is Ahmed Shafi? Oh, he's a major surgeon in Egypt, professor, da. Okay, how old is he? He's probably in his 60s. الكلام ده مثلا كان في 2002. 60s or 70s probably, even الكلام ده ساعتها يعني. Okay. So I don't get it. اتقال لي باللفظ كده يعني بما معناه هو حرامي. انا وما اقصدش حاجه عن الشخص كشخص، اوكي؟ لان هو يعني طبعا هو يعني الراجل ما شاء الله علامه، مش مختلفين، مش دي النقطه اللي احنا بنتكلم فيها. بس انا بتكلم في ايه؟ ان هم قالوا الرد اللي هو ازاي هو عنده within the last 10 years يعني وهو استاذ كبير، ما بنتكلمش حتى من زمان، عنده فوق البي publication as a first author. ازاي؟ طب هو عنده وقت يكتب ولا عنده وقت ان هو ايه؟ يشتغل. Authorship is important. Know the order of the authorship. الحاجة الثانية اللي احنا بنزعل منها هنا ساعات لما بنبقى لسه بادئين وحاسين ان احنا اشتغلنا شغل كتير وتفاجأ ان الكونسلتنت ايه؟ راح قايل لك طب انت ما حطيتش اسمه فلان ليه؟ SPR قاعد جنبك باشا ما عملش اي حاجة خالص وانت تبقى هتتشال وتتنكت ليه وليه ما عملش حاجة. Sometimes يمكن تحتاج ان انت ايه تفوت حاجات for the sake of politics. بيبقى انت علشان انت لسه you haven't published yet انت محتاج له. The extra name كون ان هو يتحط نمرة 3 ولا نمرة 4 وانت اللي كاتب البيبر ومحطوط نمرة 1 انت ما يفرقش معاك حاجة خالص ان في فلان او علان اتحط زيادة. Makes no difference with you whatsoever. راضي الناس، خليهم يتبسطوا منك، خليهم يطلعوا لك البيبر ما يوقفولكش. والواحد اكتشفه بعد كده ان هو ساعات كتير انا دلوقتي بقيت بتسأل السؤال ده، وفلانة دي نحط اسمها ليه؟ او فلان ده نحط اسمه ليه؟ ما عملوش حاجة. بس لا، لانه فلان ده has another PhD student who has helped you and they're the supervisor of that PhD student. So I'm putting the PhD student but I have to put them as well. Okay? المهم ان انت to go on as an author لازم تكون عملت حاجة من الأربعة دول. either ان انت included في الستادي ديزاين والconception او انت كتبت او ان انت الفاينل approval of the manuscript او ان انت you're accountable for the manuscript. وفي تشيك ليست بيقول لك هل في shared first authorship ولا لا، وكل واحد عمل ايه في البيبر. اخر حاجه قبل ما نروح او يعني البلاجيريزم. خلي بالك وانت بتكتب او انتوا بتكتبوا انه you're not plagiarizing حد تاني. It's very easy to find out if you have plagiarized. حتى if you're referencing what you've written, never put something in exactly the same words. You have to paraphrase. There are different tools to find out if you have plagiarized. and الواحد بيكتب بس subconsciously ممكن تلاقي ان الكلام اتكتب قريب من حاجة تانية published. There are different tools. أفضلهم Turnitin. Do not use it. Turnitin is the best. The problem with Turnitin, if you use Turnitin, you submit your work into Turnitin, it will come back and tell you there is 20% مثلا مثلا plagiarism. we highlight الحاجات كانت فين. مشكلة Turnitin إن هي centralized. وكل الجورنالز شغالة على Turnitin. The next time you go and submit it, هيطلع 100% plagiarism. ودي حصلت ان ساعات بيبقى مثلا حد من الطلبه عندنا ما عندوش اكسس للترنتين يروح مدخلها باسم حد تاني من الطلبه، فظهرت في الاول ده كويسه وبعدين ظهرت باسمه هو 100% plagiarized. فبي كيرفل. لو هتستعمل استعمل جرامارلي. في سوفت وير اسمه جرامارلي وفي دوبلي تشيكر وكوبي ليكس وكيو تكست. يعني you can check using other things. That's the structure of your manuscript. You have to write your conflict of interest, funding, disclosure. في study design that's the structure. هم موجودين على slides, we don't have to go through them. أهم حاجة بس وإحنا بنكتب آخر slide ال endnote. If you're writing references, find out what type they're looking for. The best software to use is EndNote. It's available from most of the universities and it's not that expensive even. But هتيجي إن أنت بعد كده you've done it Vancouver style. أنت مش عارف يعني إيه Vancouver style. هو هيعملها لك automatically. Thank you. إحنا ما اتكلمناش في statistics. أنا مش عارف في أصلا مجال إن إحنا نفتح باب الأسئلة. خليها بعدين.
تعقيد صغير جدا بس بعد اذنك، هل الليكتشر ده موجود على الويب سايت بتاعنا ولا عشان الشباب كلهم يسجلوا فيديو؟ It should be على الويب سايت بتاعنا لو هو حاطه as a slide.
We can make sure it's up. هتفهم مع هاني when we make sure that it's up. The slides will be there والفيديو.
نمرة 2 بس تعقيد بس يا شباب صغير، يعني للناس اللي هم كانوا في البانل اوف ذا انترفيو، يعني كانوا انترفيو جايد، انترفيو فور الريسيرش ده هو نقطة ضعفنا، وللأسف الشديد هو completely 1/3 of your assessment in interview للأسف. يعني 30% من الانترفيو بتاعك علشان الجوب بيبقى على الريسيرش، ولو انت عندك الديفكت ده يبقى انت بتاخد من 70% بس. فطبعا هم مش هيدوك الوظيفة إلا إذا كانوا هم ستاك أو ما عندهمش حد تاني، لكن لو عندهم أي حد تاني عامل ريسيرش definitely they will take it. فدي very important، يعني we have all to work hard for that. ربنا يوفقنا.
لو في ريسيرش يعني 2 3 يعني حاجه بس.
ما هو الفكرة بيعتمد على مش بس زي ما وائل قال، هو انت ما بيقولكيش انت عملت ريسيرش ايه، هو المفروض ان هو بيعمل معاك انترفيو كده سريع لو عايز يديك الوظيفه وخلاص لان ما عندوش حد. لكن البروبر ريسيرش انترفيو يبقى فيه في البازل 3 واحد منهم يبقى ريسبونسبل فور انترفيو فور ذا ريسيرش، بيسالك انت عملت ايه، تقول عملت كذا، يقول لك عملتيها ازاي وطلعت منها بايه، بيسالك ان ديتيل وات يو ار سينج، وهل هي لوجيك ولا لا. بالظبط كده. لا في كله، وحتى في الكونسلتنت في الاس بي ار everything for all doctor job the research part is the main part. How many paper published و how many paper you presented in international meeting، وايه الانترناشونال ميتنج دي، وايه الجورنال اللي عملت فيه ابلكيشن، ده شيء مهم جدا. احنا للاسف الشديد ده نقطه ضعفنا، لان احنا ما تعودناش زي ما وائل بيقول، لان وائل بيدرس في جولوي. الطالب هنا في ايرلندا يعني بيخرج من الجامعه سنه 5 بعد 5 عامل على الاقل 3 بابليكيشن، مش عامل 100 ريسيرش منهم 3 بابليكيشن. فاحنا طبعا الحاجه الوحيده اللي احنا عملناها في حياتنا هي الماستر او الام دي اقصى حاجه. مفيش حد فينا عمل بروبر ريسيرش، ودي ديفكت مهول عندنا للاسف.